Welcome to CARP's expert panel on adult immunization. I'm Marissa Semke, Director of Policy at CARP. Now, governments in this country, and certainly here in Ontario, do a very good job of covering childhood vaccines and promoting their widespread adoption. But with so much emphasis on childhood vaccinations, is government doing enough on adult vaccinations? Children in Canada today are protected with a long list of vaccinations that help to prevent viruses and infections, including polio, pneumonia, measles, mumps, rubella, meningitis, chickenpox, and hepatitis. Those protections are not offered in the same way to older Canadians, who, like children, are at a higher risk due to their age. As we get older, our body's ability to fight off infection weakens as a result of a decline in our immune response through a process called immunosenescence. Our experts gathered at the roundtable today will tell us more about the importance of immunization for older Canadians, and will discuss some of the latest breakthroughs in vaccination technology for older adults. Dr. Iris Gorfinkel is a family physician in Toronto and a principal investigator and external peer review contributor for the Canadian Medical Association Journal. Andre Picard is the health reporter and columnist at the Globe and Mail, where he's been a staff writer since 1987. He is also the author of 3 best-selling books. Dr. Mona Saberwohl is a pharmacist and the Vice President of Industry and Regulatory Affairs at Rexall. She's also a director at Kidney Cancer Canada. And Anne Van Buren is a patient of Dr. Gorfinkel who's experienced shingles and is still dealing with its effects. Thank you all for being here today. Dr. Gorfinkel, why don't I start with you? Can you give us a quick overview of some of the vaccines that are recommended for adults aged 50 and older?
Absolutely. The concept of immunosenescence is a critical concept. As people get older, the body's ability to fight off infections is less. And for that reason, it is important that everyone over 50 ensure that their vaccinations are up to date. Those vaccinations include familiar things like tetanus, diphtheria. We all need 1 adult dose of pertussis. We should be getting hepatitis B and hepatitis A if we're traveling, especially, because that's good for a lifetime. We should be getting the pneumonia vaccination. So if we're immunosuppressed, especially the Prevnar 13 and the Pneumovax 23, 2 doses of that, 5 years apart. And then finally, of course, the shingles vaccination, a critical vaccination, a brand new vaccination in our armamentarium, the Shingrix, which is going to be available in January.
Now, you mentioned shingles. What is shingles, and why should we be aware of it? Why are Zoomers particularly at risk for it?
95% of us have had chickenpox as a child. It's a huge number. So the vast majority of us are at least theoretically at risk of developing shingles. Our lifetime likelihood of getting that is approximately 35%. In other words, 1 out of 3 of us are going to win that bad lottery of going on to develop shingles. So this is an unusual virus, and that after we get it, our body may not necessarily fight it off completely. The virus, for reasons we don't even fully understand, remains latent in the dorsal ganglion near the spinal cord, and then later activates, often as we get older. So with every passing decade, especially after the age of 50, the virus, instead of lying in wait, because in part of immunosenescence, our body's ability is lessened as we get older to fight infection, it reactivates. It's crazy. This virus that's been around our entire life suddenly comes traveling down the nerve root, causing a burning sensation, an itching sensation, and then a day or 2 later break out in the typical rash in 1 single nerve root. It's actually not the rash that causes the problem. It's the damage that's done to the nerve by the virus as it's traveling down the nerve's axon.
And we'll get into sort of some of the other effects of shingles in just a moment, but I want to go to you, Andre, because Ontario is the only province in Canada that's agreed to cover the cost of shingles, but only for those aged 65 and 70, which begs the question, why this 5-year window? What about people who are over the age of 70? What about a 71-year-old?
Yeah, so for a government, it's sort of cost benefit, right? They're trying to get the most bang for the buck. So the existing vaccine, Zoster, gets less beneficial as people get older. So they've targeted this group that they're going to get the most value for money. Now, other people with their private plans, out of pocket, can get the vaccine if they wish, but government has this really careful balancing act. They can't pay for everything for everyone, so they try and get the groups who are going to have the most benefit. And that with the new vaccine, that may change, because a really good thing about the new vaccine, the new shingles vaccine, is that it works better in older people, better than the former vaccine. So we may see an expansion of the criteria, but it'll probably be slow and careful on the government's part.
Now, while seniors are particularly vulnerable to shingles, I'm hearing increasing stories about people in their 30s getting shingles. And I understand the trials, Dr. Gorfinkel, were conducted in people aged 50 and older. But what about folks who are younger than that are also at risk for shingles?
The trial did not examine that patient population simply because there are not enough of them. So in doing the trial, we want to make sure that the participants in the trial have enough to gain. If I'm 40, the likelihood of my going on to develop shingles is much less than if I'm 60, which in turn is less than if I'm 70, which in turn is less than if I'm 80.
But the disease is still so severe. I mean, wouldn't government, or even Health Canada for that matter, want it to be available to people that are at risk?
Well, initially when a large company is deciding to do a clinical research trial, we don't know if it's going to be effective or not. So we want to strike that beneficence, the ability to provide a patient more than what we're potentially taking away from that patient. So if their likelihood of getting the disease is really low to begin with, it gets hard to justify why we should give a vaccine, which was experimental at the time, to that kind of a patient.
Anne, you've had shingles. I have. Can you walk us through your experience?
I was diagnosed in mid-February. I did not have the typical rash. I had 2 blisters in the palm of my hand and a few red blotches all the way along the nerve path, and within a week developed absolutely debilitating pain in all my right side. I'm a teacher. I was not able to complete the school year. I was unable to use my right hand, right arm. I'm almost healed, but I still have very, very severe pins and needles in my hand. I don't have feeling at the tip of my fingers. I'm a knitter. I haven't been able to knit for all this time, so I can't wait to...
You were right-handed too, right?
I am right-handed. I could not write. For 2 months. I just could not do anything with my right arm. Then it was fairly easy to type at the computer because the touch is light. I still have a hard time writing by hand. If I have to write a check, or it's hard.
You were diagnosed in February of this year.
Yes.
And so now it's December.
Yes.
Almost a full year
Yes.
you've been dealing with the effects of shingles. Unbelievable, and it's very painful.
Yes.
When I talk to patients, I often talk to patients, someone recently told me it felt like I was wrapped in flaming barbed wire. Like the pain can be really severe and intense. Nerve pain is really horrible. And as Anne said, it can continue a long time. I've heard people have effects 3-4 years later. It comes back when they're stressed or mostly. So it's a lingering and it's a horrible illness.
And it can manifest itself in any place on your body. I mean, in your eye, for example.
People have been blinded by shingles. People have, the inability to write and things they lose. So it can affect any nerve in your body.
It's unbelievable.
I think the key for patients to understand is that early recognition is key. Vaccinate if possible, and recognize the disease early on. So the telltale thing that tells a doctor, the pain can be helpful because if you describe the pain as something unique in a single nerve root, these are the key things. We look for a rash because the rash is the one thing that we can hang our hats on and know that we've got our diagnosis. So the rash is typically small papules, which are they look almost like little acne initially. And then they change into water blisters, and the water blisters break and crust over. And often there are different stages of healing. So if you can remember what chickenpox was like, this is like a mini chickenpox in one single nerve root, usually just on one side, not on both sides. So if it's both sides, it's probably not shingles. It's on one single stripe, one side.
Is Anne's experience typical of most people that have experienced shingles? I mean, what's that, 10, 11 months now that you've been dealing with it?
Anne she had a really terrible case. I mean, as her doctor, it was a tremendous challenge to treat, as is usually the case with postherpetic neuralgia. The things that predict bad outcomes, being a woman is a bad prognosticator. Being older is a bad prognosticator, especially if you're immunosuppressed. You know, taking a biologic, say for rheumatoid arthritis, those patients also have a much harder time. HIV patients have a much harder time. But no, she's not typical. I would say she's far worse than the usual. PHN overall, postherpetic neuralgia, affects approximately 13% of individuals with it. It's by no means the rule, but it can be extremely life-changing and debilitating. And
we talk about the sort of impact of shingles. It's not just on the individual that's impacted. Our healthcare system is impacted. What's the true cost to our healthcare system when we think about someone who's been diagnosed with shingles and perhaps hasn't had the vaccine, has to go through the system of being treated? Who can speak to that?
Well, there's the cost of treatment, but I think the biggest cost is what Anne said, is you miss work, you suffer. A lot of people cut back on their work, just because they can't, because of the pain. So I think it's the societal impact. It's really difficult on your spouse. You know, you're 80, you have an 80-year-old spouse who has to take care of you when you have this awful rash and you're in great pain. It's hard on people in a whole number of ways.
And it could also affect your family. If you're the primary caregiver for your children or for your elderly parents, you're not able to do some of those activities that you would normally and support your family. So someone has to pick up the slack, and that also causes a burden to the entire family.
I don't know how I would have lived through this without my husband. He had to do practically everything for me, including opening my toothpaste so I could brush my teeth. I mean, just about everything.
Mona, how do I get the shingles vaccine if I want it? Can I just walk into any pharmacy and ask for it?
So it's actually complicated, unfortunately, in Canada. Ontario, as you mentioned, is the only provincial government that covers shingles vaccine for a very narrow population, that 65 to 70-year-old population. For others, if you're 50 to 64, or if you're 71 and older, you would have to go to your doctor to receive a prescription. Then you would take that prescription to the pharmacy, get the prescription filled, and then you have two options. You can either take it back to your physician to get the vaccine injected, or for a fee, you could ask the pharmacist to inject that for you. So that's in Ontario. In other provinces, it does vary. Alberta, you will need a prescription and then take that to your doctor or again to your pharmacy to have the vaccine injected. In BC, the pharmacist can actually prescribe as well as dispense and inject.
And what's the cost associated?
The current vaccine costs about $200 for the dose, and then if you receive or ask the pharmacist to inject that for you, it's about $20.
Now, from a public policy perspective, why do you think it is that provinces like Ontario haven't funded a vaccination program that would cover necessary vaccines? And this seems fairly necessary, like the shingles vaccine, despite knowing all the health and sort of economic consequences that are associated with it, Dr. Gorfinkel.
It's not unlimited. The budget is not unlimited. It's very difficult. The province is always facing cost-benefit analyses with every single decision they make on every medication. And so this vaccination falls into that large category of what are we going to pay for and where is the cost benefit. So presumably there are epidemiologists who've made this decision that in terms of the likelihood of getting disease in conjunction with the efficacy of the vaccination and the fact that the efficacy wanes over time. In other words, if I get the vaccine and I'm 50 when I get it, by the time I'm 60, there's not much of that vaccine efficacy even left in me.
Oh, so should you get it again?
We don't know the research on that. So that's a problem. The research that we have, unfortunately, it doesn't show, we don't have revaccination or booster research.
Mm-hmm. And I think that's the biggest impediment to government funding right now. It's expensive, so there's some leeriness, but the real leeriness is, are we gonna have to do it again and again and again, and then the costs multiply. So I think we're gonna see over time some adjustments. If we find out the new vaccine, for example, lasts 15 years instead of 5, then there'll be different policy decisions based on that.
Speaking of the new vaccine, there was a recent article in the New York Times entitled, "No Excuses, People, Get the New Shingles Vaccine," okay? And a part of the article read this: Shingrix racked up a 97% effectiveness rate in adults over age 50, and in a separate study of people over age 70, prevented 90% of shingles in those 70 to well past the age of 80. So let's talk a little bit about Shingrix. What is it?
First, I have to get on my knee and thank all of those 30,000 individuals who decided that they would be a part of that vaccination trial. You cannot imagine what it's like to be offering your arm and saying, here, vaccinate me with something that I don't know will be effective or not. So I owe a tremendous amount to those patients who said, you know what, I'm willing to do this. I know it's a bad disease, and I think we should try to see if we can do better. So first, I want to thank those patients. That's a huge thing. And they stayed in the trial with unbelievable tenacity, because these patients who started out, virtually all of them finished in virtually all of the sites. So that's an amazing thing, like 30,000 people. So that aside, I'll come back to the original question, which was?
Which was, tell me a little bit about Shingrix. What's this new vaccine everyone's talking about?
So the vaccination has nothing to do with a live or attenuated viral vaccination. So in theory, at least, it could be given to patients who are immunosuppressed. So that's a big difference over the old product, Zoster. So the Shingrix is a very exciting vaccination that it's like a researcher's dream. We can work forever and never have a trial that's this positive. This is unbelievable. 97% of efficacy. It's a game changer. It's going to take a disease which is common, and it's almost going to eliminate the disease. It's going to make it into a rare event. You know how infrequently that happens in medicine? Answer, almost never. I mean, this is like a major in medicine.
And Mona, other than, the way its makeup is different from the existing vaccine, its effectiveness, as you mentioned, has also been increased dramatically.
You have to also remember, though, every vaccine decision is balanced between the benefit of the vaccine versus the side effects of the vaccine. And in this case, if you've heard Anne's story, even my story, I had shingles when I was 35 years old, and it was an extremely painful experience. I was lucky. I only had it for about 3 months. It was on my face, but for those 3 months, I could not sleep because it was literally the searing pain on my face the entire 3 months. So when you think of the quality of life improvement that you would see by getting the vaccination, you have to obviously make that decision in conjunction with your physician or your primary care provider. But from my perspective, those benefits outweigh the risks.
I think what you're referring to is not technically a side effect, but there's a lot of anecdotal reports that this vaccine hurts more. So we know that some vaccines just hurt more, and it probably has to do with the adjuvant. So it's a little bit painful, but it doesn't compare in any way to the pain of shingles. So that's important. The other downside, if I could put it that way, is this vaccine requires 2 shots. So you get twice as many needles. Some people don't like needles, and it'll probably be more expensive. So there are some downsides, but they're, I think, overwhelmed largely by the science and by the effectiveness of the drug.
Sure. Now, it's been approved in Canada. When will it be available? In January.
I believe it will be available for sale in January. That's what we heard.
Where else? And where will it be available?
Nationally, I think the biggest question, though, will it be covered by governments? And as our other panelists have already talked about, that is a process that every government undertakes to understand if it would be publicly funded or if individuals will be required to pay out of pocket.
So a big piece that's missing in that is how long will the vaccination last? And we're participating in a trial which is ongoing. So the original group that was vaccinated, so half were vaccinated, half received placebo. So the half that was vaccinated, we're following now for another 6 years. to try to see how long does the immunity last. So that's the million-dollar question. How long does the immunity last? Did I say million? Sorry, I meant billion-dollar question. Right, Andre?
Multi-billion-dollar question.
So the multi-billion-dollar question. So there you go. So that's the question.
So if you've had the vaccine, can you get it a second time? Does it make sense?
Which vaccination are you asking about?
Well, I suppose the old vaccination.
The Zoster, I think it's safe to say, is probably not what doctors are going to be giving at all. I think that vaccination has become obsolete, or will become obsolete the day the Shingrix is widely available.
Okay.
And that's an ongoing process. So I would say that that's kind of a moot point with the old vaccination at this point. There is no great data on booster shots with Zostavax that I'm aware of. You know, originally, the original data set looked at one vaccination, and we know that immunity goes way down. Within a decade, you're left with a small percentage of what the original immune effect would have been. So, for example, if you're a person in the 50s who received the Zostavax and you wait a decade, it starts out with about a 65% efficacy, and it drops down to close to 20% after 1 decade. If I got it when I was 65, and now I'm waiting, now I'm 70, the efficacy drops from about 45 to 50% to about 20%. Wow. So there's a large drop in efficacy with that vaccination. With Shingrix, we actually don't know how long that vaccination will last.
So many people that have had the existing vaccine will likely then get Shingrix as well, or?
Well, that's what the U.S. recommendations say, that you should be revaccinated with this new vaccine. Canada's formal recommendations, there's a group called NACI. They haven't been published yet, but the U.S. recommendations is, yes, get revaccinated.
And if you've had shingles, does it still make sense to get the vaccine?
What I think what doctors will tell you is if you've had shingles, you have some natural immunity for a couple of years, and then you should probably get the vaccine.
Yeah,
that's right. Actually, there is no clear consensus on, when should we vaccinate after someone's had shingles. What we think it is it's probably 3 years. Probably you're okay for a couple of years at least. The recommendation, because the likelihood of going on to develop shingles a second time is actually 20%. We used to think, once you've had shingles, you're not going to get it again. We know that's not true. 1 out of 5 individuals is going to go on to get shingles a second time. Yeah, it's really frightening. So those individuals do need to be vaccinated, even if they've had shingles, and probably, depending on your doctor, 1 to 3 years after.
So what will it take then to get this drug on the provincial formularies?
Well, the evidence is the first thing, and it sounds like there's very, very good evidence on efficacy. The long-term effectiveness will also come into play in the government's decision. And then all governments look at cost effectiveness. So they look at all the benefits that a drug or a vaccine may provide for a population over a long term, and then the costs of those of the treatment and all the potential side effects that are avoided. So they kind of do this cost-benefit analysis, and they make their decision based on what that evidence shows. The evidence, like I said here, is very good, and as we get more evidence around the long-term effectiveness, I think governments will hopefully come online. But they have to prioritize adult immunization, and I think that's a key principle that many governments are looking towards as they're trying to reduce the burden on other parts of the health system.
And then for what age group do we cover the cost for? Is it still the 65 to 70, or would you support expanding it?
Oh, I would definitely support expanding it, but I don't envy those people who have to make that choice, because there's going to be a lot of pushback from individuals who want the vaccine who aren't going to be able to get it. It seems incredible to me that they would decide to vaccinate absolutely everybody over the age of 50. So if you look at NACI, the Canadian people who make recommendations to doctors like me to tell us what we should be doing, they're probably going to start a little later for the government coverage for it, but I'm not sure what they're going to do. I don't think they know yet. So,
and I'll tell you practically, the way new drugs and new vaccines can tend to get adapted in Canada is the company will make a deal with one province. They give them a really good price. They'll have a universal program of some sort, and then other provinces will feel some kind of need to follow suit if it works out. So things in Canada tend to be, there's a political element to how drugs are purchased and approved. So it'll take a bit of time.
Also, exactly, that takes time.
Yep.
I mean, how long can we expect for that process to run its course?
Oh, it'll be years before there's any semblance of a national program of any sort.
Now, I'm interested in sort of the role that pharmacists play in educating adults of all ages about shingles and how they can protect themselves from their loved ones. Muna, can you speak to that?
Absolutely. So we know from the evidence that prioritizing preventative treatment can really increase the rates of those treatments, and specifically in adult immunization, when you have a focus on preventative treatment, such as flu immunization, such as pneumovax vaccination, such as shingles vaccination, through multiple channels, whether that be through family physicians, nurse practitioners, or pharmacies, then you do see increases in immunization rates, which are really vital. It's not just a convenience play, but it is making it more simple for patients to actually follow through on their good intentions. Many people want to be vaccinated, but it becomes hard for them. They have to go see their doctor, then they have to go get the vaccine, then they have to go back to their doctor. Sometimes they don't have a family doctor, so they have to make all these arrangements. And so by the time you're finished with the process, you're exhausted, and you may not follow through. So increasing the opportunities and the providers that can provide you the vaccine will increase the rates of vaccination, and that's been proven in Canada and the US.
You make a really good point that vaccination should be as easy for adults as it is for children. We put lots of emphasis on children, and we've kind of forgotten that there are great vaccines and necessary vaccines for adults.
Yeah, it's one thing making the vaccine available and funded, but then having access to it is another important factor. And we know reducing barriers, of course, increases vaccination rates.
One of the complicating things is that as people get older, there's a lot of competing interests for the doctor's time. So if my patient has to wait, and we have same-day appointments, I really try hard, but if they have to wait a few days to see me, then they usually bring in a list. And the list, I'm not kidding, it can be literally 10 things long. Yeah. And where does vaccination fall on that list? I've got my diabetes, I've got my hypertension, I've got my hyperlipidemia, my elbow is itching. Like, I'm just telling you, like and my mother is depressed. And I'm looking after that mother. Like, this is typical visit.
Sure.
Like, it's not, we kind of laugh and chuckle, but it's actually, this is life. It's complicated, it's messy. There's a lot of different things going into our minds in that visit. So I think in order to get vaccinated, we actually have to put it toward the top of the list and say to the doctor, I'm worried about my risk. I need to talk about my vaccinations and make that a priority in the doctor's visit. So instead of it being number 10 on your list, move it up, because actually that's the low-lying fruit. That's easy to take care of.
Now, before we go to, I think we have a few questions from the audience, which will be wonderful, but let me just go lastly to you, Andre. I'll circle back to sort of my original question, which is, is there ageism in how the government provides vaccinations to Ontarians, or across any province for that matter? It seems like children, and certainly they're in a position where they definitely need those vaccinations available to them, but seniors are equally at risk, I would argue. So would you say that there's maybe a little bit of ageism in what's going on here?
I don't think there's so much ageism as there is not the good science. So there's incontrovertible evidence about childhood vaccines. They tend to protect you forever. So they have really good cost effectiveness. You can't go wrong if you prevent a baby from never getting sick from an illness for 80 years. When you start at 50 or 70, the cost effectiveness is a little lesser. The science isn't as good. The adult vaccines are newer. This notion that vaccines prevent disease forever, that's going out the window. It's, we're changing our approach and our expectations from vaccines. So I think there's a lot of complicating science in there. I don't think ageism is the word to use, but it is, I think there's some neglect, I would put it that way.
Does anyone have any additional thoughts?
Well, it's difficult. As people get older, especially when there's no coverage, never mind competition for the doctor's time with a problem, you've got a limited wallet. Where's that wallet going to go? You know, you've got your housing, you've got, you know, your basic food expenses, you've got your internet, whatever it is. How much is left? How much is left on that dollar?
And will you get the Shingrix vaccine?
I certainly will.
I will make sure she does.
She was rolling up her sleeve a little earlier. Give it to me now.
Okay, is there a question in the, there we go. Can you tell us your name?
Yes, my name is Ranny Glick. I have two questions. One, if you're already compromised with some immune problem, like having rheumatoid arthritis or something else, aren't you at higher risk of getting not only shingles, but complicating other issues that you have? And my second question is, I have a neighbor who's had shingles in tremendous pain. It's been going on even longer, his side effects, and he now has a device that he puts on his leg that helps deal with the pain. Are you aware of that?
Yes, I am.
And if you can talk about that, please.
So I imagine you're talking about the Quell device, which is a form of transcutaneous nerve stimulation.
Yes.
And we're getting into something slightly different but related. The general approach to pain, you want to max out on absolutely everything that can be done superficially before you go into the systemic stuff, right? So I like that kind of a system. I'm a big proponent of creams, heat, ice. Like, these things make a big difference. Why should we start that before, you know, we definitely should start those kind of things before we start systemic things that could affect the entire body. You know, so yeah, that device can be effective, but unfortunately the treatment approach to post-herpetic neuralgia is a complex one. These are complex regional pain syndromes that require specific drugs that attack nerve pain. And I'm not talking about opiates. I'm talking about drugs like pregabalin or gabapentin. My go-tos in treating that kind of pain. It's horrible pain. And as far as having rheumatoid arthritis, you're absolutely right. Once you have one autoimmune disease, you're at risk for developing not only other autoimmune diseases, but you're more likely to be placed on a biologic drug. And unfortunately, with where we are now in terms of our knowledge, we don't just attack the antibody that's at fault. We attack the body's immune system as a whole in order to get that single antibody down. And that's a problem because that raises the specter of immunosuppression. And if we're immunosuppressed, that allows that chickenpox virus to come traveling down the nerve root, and voila, we have shingles and the risk of post-herpetic neuralgia thereafter.
Thank you. Yeah, I think that's a real issue, is when people their immune system is compromised to be taking a vaccine of that intensity.
Well, that's the thing. The original trial that we had done, the Zoe 50, Zoe 70 trials, looking at 30,000 individuals, specifically excluded the immunocompromised. However, at least theoretically, there should be no reason why those patients should not be able to receive that vaccination. And that's in contrast to the Zostavax, because that's a live attenuated viral vaccination, and those are an absolute no if there's immunosuppression.
Okay, thank you.
So in theory, we could actually see greater benefits, particularly for that population, that immunocompromised.
Not just in theory, but very much in practice. I think we're going to be seeing that patient population who's right now extra vulnerable for not only having shingles, but for suffering post-herpetic neuralgia. I think we can look forward to them having the vaccination and having that added protection. And we still need more data.
What size is that population, the folks that are immunosuppressed?
Oh my gosh, I don't have exact stats on that. Do you know, Andre?
I don't know, but it's a fair number. You know, a lot of people have cancers, rheumatoid arthritis. It's a large number, and it's a growing number.
These biologics that that you were talking about, Dr. Gorfinkel, are very prevalent in the community. So whether it's rheumatoid arthritis, inflammatory bowel disease, if you've ever had a transplant, though you're on treatment that are specifically suppressing your immune system and then leave you susceptible. I mean, what we see in the community is it's a fairly significant number.
It's the biggest spending category of drugs, so it's a fairly large number. Yeah.
It's a huge percentage of the drug costs. Biologics are an increasing increasingly larger part of the pie.
Now, I think we have time for one more question, and there was a lady in the front row. Okay, we'll take 2 more questions, okay?
My name is Judy Treitz. I'm curious about a friend who had shingles a couple of years ago. She recognized what it was right away, went to her doctor. Her doctor gave her some sort of antidote treatment that reduced the terrible effects of shingles. Have I got that straight? Is there some sort of antidote?
Yes, there is, and I'm so glad you raised that, because it's critical that treatment, which is antiviral therapy, be started within 72 hours of the onset of the rash. So good for her for recognizing it. And that's one of the key things of this. I'm hoping that if any one of you experience that kind of a rash that I described before,
yes,
or that kind of a pain, it's critical that it be recognized, diagnosed within 72 hours so that the doctor can get the antiviral on board. And that doesn't cure us. It still doesn't cure us, but it does reduce how contagious we are to other people. It reduces the severity of the illness, and it reduces how long the illness will last.
Excellent. Thank you very much.
Thank you for such a great question. That's important that people know about that.
Hi, my name is Barbara Young, and I got shingles when I was 84 years old. I had a terrible pain in my head and went to the emergency, and the doctor came in, asked me questions, and he laughed. He says, "You're going to have shingles tomorrow." He gave me a prescription, but he said, "Do not fill it until you speak to your physician." That was Thursday. Now, I didn't get to see the doctor till Monday, and that was too late. And believe me, I have gone through hell. I still have it. It's on the left side of my head, into my scalp. My eye is very bad, and it's just a numb feeling. And I don't know if I'm ever going to get rid of this.
You know, that 72-hour window is such a critical window.
Right.
And although it's easy to look back and say, had I just started the drug,
right,
I don't know for sure that the outcome would have been that different had you even started it.
Maybe a little milder.
You know, possibly, but you know, we can live our lives filled with regrets and looking back, or we could say, I can't know. And if I'm saying I can't know, then really don't take that brick and keep hitting your head in that same place with that brick. Don't do that. That's not good for you. What's much better is saying, you know, perhaps with this platform, you're reaching out. Perhaps because of your story, many other people have learned. And now we know within 72 hours we'll get the care, we'll get the vaccination, we'll prevent that from happening. And there can be meaning in terrible pain. And maybe your doctor can give you one of those drugs that I'm describing, that pregabalin or gabapentin.
I take the pregabalin.
You're on
and
that.
And I've taken Lyrica. Anything doesn't seem to help me.
How long have you had it for?
Since July of 16.
Wow.
Maybe over time it'll go down. It often does. It often does. I know that sounds like it can never happen when you're having so much pain, but we should use multimodal pain control. When there's a complex pain syndrome, do not rely just on one thing. The combination of things we do, that's often where the answer lies.
Well, I've been to a neurologist who sent me for a CAT scan. He says he doesn't believe that the pain could be so long.
You know, so the combination of drugs, and I don't know your medical history or anything, but there are many other things that are used for chronic pain, and not just pregabalin. There are other medications, including topical things, including other systemic drugs that may make a real difference. I would be very open-minded to other things, including acupuncture, that can make a difference. Don't give up. Keep trying to raise the bar and seeing other health practitioners. Rarely does one doctor have all the solutions, and I'm certainly not that doctor. But if we add on, you know, the knowledge and the experience of multiple physicians, often the pain, we cannot eliminate it, but we can make it reduced. We can reduce it significantly.
Are you going to tell me eventually this will go away?
Over time, it probably will get better.
How much time? It's like...
I cannot predict the single individual, but over time, the body's immune system eventually gets on top of it.
Thank you.
And that's the question I think that everyone wants to know. If they get this, how long will it last for?
Yeah, it's very hard to speak in terms of individuals.
My experience was 3 months.
You made a full recovery?
I made a full recovery, but I think it was because I was younger at the time. But you know, other people can, again, patients have expressed to me that it could last a year, if not longer. But I think, I mean, the whole point of this discussion is then to try to prevent the shingles from happening, making sure that you prioritize wellness and prevention and get the shot and get the protection. It's never, no vaccine is 100%, but 97 is pretty close. And so, I mean, that makes it very clear to me that this is something we should prioritize.
Would you then advise that lady in the audience to get the new vaccine?
Well, Dr. Gorfinkel, I think you suggested that there's still a high rate of recurrence once you have had shingles. I know for myself, I can't make a decision for somebody else. For myself, I'm very interested to get vaccinated, given that I've had it in the past, and I have some immunosuppression currently. So.
Yeah, well, I think you would have to speak to your physician about your own medical problems and what other drugs you're on and what may interplay with that. But my advice to you would have probably been, you know, knowing what limited information I have, is that you should get vaccinated. You had very aggressive disease. It would be between you and your doctor who has a bigger picture on you. I really don't know that bigger picture.
It's advisable to get it now, even though I still have it?
As I said, I do not know the bigger picture, and I'm not trying to just pull out of this. I really do not know your medical history, and that's a big minus. So that your personal family physician should talk to you about the benefits and the risks of that vaccination. But generally speaking, you would be hard-pressed to justify why you would not provide that vaccination to somebody. You know, I would want to see a person who'd had aggressive disease, who's suffering a lot, get that vaccination sooner rather than later. But that said, that's between you and your doctor to decide.
Okay, thank you. All right, so we just have a few minutes left, so I thought maybe we would go around the table, just give some final thoughts. Any advice perhaps you have to the audience, whatever you're thinking?
Yeah, so I think what we've heard over and over again is that the only thing predictable about shingles is its unpredictability. So the best thing we can do is to try and protect ourselves as much as possible with a good vaccine. So that's the number one, and then if you get it, act quickly to get some early treatment, use all kinds of treatments, use everything that's available to you, and it's our chances, if we don't do these things, our chances of getting it are very high. Once you're over 80, the chance of having shingles is almost 1 in 2, so it's worth that investment. That little pain in the arm is well worth it for preventing a lot of pain in the future.
Yeah. Anne?
Get the vaccine. I'll get it as soon as possible. Well, maybe I can wait for a year, because having had shingles, I'm told that I'm kind of immunized, but I definitely will get it.
About a year or so,
okay.
No.
I think that it's very exciting times to have a new vaccine that appears to have greater effectiveness, and it hopefully will be covered by governments very soon. That being said, it probably will be some time. I encourage people to look at whether they have private health coverage to see if they can get that vaccine covered through their health insurance plan. Sometimes through a retired pension or a retired benefits package, you can often still get coverage. So I would really encourage people to see if that the new vaccine will be covered.
Okay, and Dr. Gorfinkel.
Given that everyone else in the panel has discussed the vaccination, because right now so many people are not vaccinated, I want to come back to the disease. Suspect it early if you're getting pain in one single nerve root. Suspect it early. And if you see the rash, you have to see a doctor within 72 hours, and that's where the best therapy lies. The antivirals, that's what we have, that's what's in our armamentarium right now. So until everyone is vaccinated, high suspicion of disease, seeing the doctor early, getting your antivirals, and then talking about how can I control the pain aggressively early on so that complicated pain syndromes don't set in.
Okay, well, Ontario's vaccination program for shingles launched in 2016 was a good first step, but more can be done. With the emergence of new technologies, there's an opportunity and rationale to expand the eligible cohort for the vaccine and to protect more adult Canadians from shingles. Immunization can be an important part of promoting healthy aging and reducing the impact of preventable illness amongst older Canadians. Thank you to my panelists for being here and to our audience in studio and at home. To keep up with CARP's advocacy, please visit our website, www.carp.ca. We'll see you next time.